Laura Cassidy. I'm the Network Delivery Manager for the Child Health and Wellbeing Network for the North East and North Cumbria Integrated Care Board. And I oversee the Healthier Together website and mobile app, working really closely with um, Emma, who I'll let introduce herself as part of the presentation. So I'm just going to give a little bit of background and context to the Child Health and Wellbeing Network. If you could just do move on to the next slide, please, Emma.
Sure. My name's E Lim, and I'm one of the general paediatricians at the Great North Children's Hospital, and I'm co-clinical lead of the Healthier Together programme along with Alex Battersby.
So just to give a bit of context from a child health and wellbeing network perspective, obviously we all work in the health field or education settings, and obviously understand the challenges that we have as a region in relation to poor health outcomes and obviously levels of deprivation. A lot of the work that we do around Healthier Together is based on those high rates of A&E attendances for children, particularly aged 0 to 4. And we actually have the highest rates in the country. So a part of this work is really about how we empower parents with information and advice to support them to make informed decisions. We also do a lot of work around asthma and some of the work around that wider community settings and how we support better management of asthma. And you can see obviously the levels of child poverty that impact on a lot of those abilities for families to manage conditions effectively, and also from leading those healthier lives and their well-being. If you move to the next slide. As a network, we believe all children and young people should be given the opportunity to flourish and reach their potential and advantage by organisations working together. And a lot of the work we do is around sharing models of good practice, testing out innovations, and gathering research and evidence of impact. And you can see on the right-hand side there, that's our priority wheel. And a lot of those priorities will be very similar to what you're doing yourself in your roles in relation to addressing and improving child health and wellbeing outcomes. You can see there as well, as a result of COVID, we went back out to families and to the system to understand, is there anything else that we were missing? And actually family support was an element that was added as a result of COVID. And I'm sure you agree there is a lot more, offers to families around that whole family support and looking at the whole family and how we work with families. Next slide. So from a network perspective, we have a responsibility of delivering the Children and Young People's Transformation Programme, and you can see there that heavily focuses on asthma, epilepsy, transition and diabetes, and a mental health champions programme and paediatric early warning signs, and the complications of excess weight clinic pilots across the region for children. My role is around integration, and it was very much the delivery and the development of Healthier Together as a model in our region. And we do a lot broader work there, as you can see, around addressing inequalities through the core 20+5 framework, and a lot of kind of different other projects around inequalities for looking at things like poverty proofing. So that just gives you a bit of an introduction to the network, and there is a slide at the end which we'll be sharing where you can join if you're not already a member, and we do send out lots of information around opportunities for training and development and things like that. So it might be great if you could sign up if you're not already. I'm going to hand over to Emma now, who's going to deliver the clinical aspect of the session. Thank you.
Hi, welcome. I had a quick look to see who joined us, and I could see there was loads of nurses and school nurses and people working in primary care. And when I put this talk together, what I was thinking about is, what do I see? What do I see at the front of house when I'm in the emergency department? What do I see in my clinics? What are the sort of common things that I think we can help you with and give you some hints and tips on how to use Healthier Together to its full potential? So as a quick outline, I'm going to go through asthma and viral wheeze because everybody is coughing and wheezing this winter. Touch on allergy. I thought I'd do constipation because it's like everybody is constipated, even the ones who are coughing. A bit on functional abdominal pain because I think that's something we see quite commonly. Talking about neurodiversity and tics, and then I'll have time for questions at the end. So just as a reminder, in a sort of to see what is available to you, Healthier Together exists as a website. So you can go on the website and the front page will look something like this. And your GP or primary care may have an app where parents can contact you directly through the app. We have on our parent pages, we always have a traffic light system. This is the one I use almost all the time, which is fever. And you can see what I say to the parents is, here is the red warning signs. This is when I want you to bring your child to the emergency department. The amber signs, this is when you could contact 111, or if you're on the app, contact your GP if you have any queries. Your GP may be able to reassure you or make a plan to see you. If you don't have any red or amber warning signs, it doesn't mean that your child is well, but it does mean that your child is safe to stay at home. And then below that, we have some self-care advice. So that's the kind of spiel I use when I see parents and their families in the emergency department or in clinic. And it's really important. I think we're all used to using Healthier Together for acute conditions, but actually there's so much more. So we have a whole load of professional resources and community resources. You can see here and webinars, so you can watch back if you miss one of our seminars like now. All the previous lunch and learns are on there. You can also find referral pathways. You can see the Beat Asthma School information is all housed here. And also you can see we've got extra things like vaping resources. So there's loads more to it. And since I was talking about asthma, I thought we might as well start there. And it began with A. Some of this you'll be really used to. So I think with asthma, we always think about emergency and preventative management. It's about helping families recognize the signs and supporting them with access to their blue reliever inhalers like salbutamol and making sure they have up-to-date asthma management plans. And we looked at the traffic light system, and as you can see here, it's really obvious. So the red one for asthma says not improving despite using their inhaler according to their action plan. So this will all fit with the information on Beat Asthma and should fit with your asthma plan. These are all really obvious. And then it gives the parent advice what to do. Ring 999 and give 10 puffs. The amber section is just as you expect. Again, it says if you need increased doses of your inhaler, then you're in the amber section and you might want to contact your GP surgery, but it asks you to continue following your child's action plan while seeking advice. And it tells you what to do if the symptoms persist. So the big thing for asthma prevention is your child's asthma under good control. And unfortunately, in the Northeast region, we have a really bad rates of asthma and bad rates of children coming in with acute asthma and even asthma deaths. So just as a reminder, signs of poorly controlled asthma, additional use doses of inhaler more than 3 times a week, being wheezy after exercise, and persistent nighttime cough. And I would add on that using more than 3 salbutamol inhalers a year if you look on their prescription. And these are some of the tips, and these are the things that I forget myself. And actually, these are things that our asthma nurses always go through. One of the things is the inhalers. Check your inhaler. The inhaler contains medicine, and the salbutamol inhalers have a maximum of 200 doses, but they continue to fire when they're empty. So you can shake it and you will hear the propellant and it will appear to push something out, but there won't be any active medication. This is actually a bigger problem with the salbutamol because there isn't a dose counter, whereas on the back of the kennel you can get a dose counter. And it's one of the first things our asthma nurses do is to check whether parents have got how long they've had the inhaler for and how much they've used it. And we often go back and use the Great North Care record to see how many inhalers they've had, and then we can tell if they're actually taking the medicine. Now, another thing is I see this all the time, that children come to the emergency department and they've all got the yellow air chamber with the face mask. But actually, children over 3 can use the mouthpiece, and actually it's much more effective, and then you don't have to hold it over their face. So that's just a tip that you can switch them to a mouthpiece once they're over 3. And I'm sure you'll know that you press it and encourage them to take 5 slow breaths or count to 10. Avoiding triggers and asthma triggers is really important, and I don't think we talk enough about this. So, for example, secondhand smoke is a huge issue. Um, and I do talk to parents. They always say to me, without fail, I never smoke in the house, I smoke in the garden. I talk to them about changing their clothes, having an outdoor coat, washing their hands and face when they come in, and thinking about where the secondhand smoke lies. And remember, children who are on Clenil or another preventers should get a flu immunization every autumn. This is a really nice drawing. This is asthma triggers in a home setting. It comes from the Beast Asthma website, and I find it's a really useful resource to talk through with parents. So if you think about the bedroom, we'll start in the top pink bedroom here. Are the carpets on the floor? Thinking about dust mite. One of the really useful things is you sleep on the bottom bunk, all the dust mite from your siblings' mattresses falling onto you. So any asthmatic children should be on the top bunk. Minimal soft furnishings means all the teddies have to come out of the bed. They can be put in the freezer to get rid of dust mites. In the bathroom, we know there's problems around condensation and damp and mold. It does mean like opening the windows after showers, making sure there's adequate ventilation, and not using aerosols, not letting the teenagers spray things all over the bathroom. Gas cookers can be a problem. If you're cooking and you don't have an extractor fan, so you've got like fumes in the kitchen, that can be an asthma trigger. The one that I've actually seen quite often is here. It's the open fires and wood burners. So there's a lot more people burning coal and using wood burners, and they have really high indoor pollution. And I've got several children whose asthma was directly linked to that. Thinking about car fumes and pollution. This is really important when you're thinking about how children are walking to school. Can they walk on a route that avoids the most polluted places? And also thinking about pollen. A really quick one is you often hang the washing outside, but if your child has hay fever, then you need to dry their washing inside, not outside. So I think this is a great way to talk about asthma triggers. Obviously, one of our big things is getting everybody to know the same information. And that's where Healthier Together is really great, because it's all in one site. So you know they have asthma, they know they have asthma, but you need the parents, the child, the young person, and the school to know. And the school needs to know their triggers and their treatments, both emergency and preventative. So all the Beat Asthma school-friendly policies and all the asthma work is on the website, and you can just download that. So that schools, I did see there was a school nurse there, so you can download all those letters where the school says after they come in from games, they're really wheezy. So you give that to the parent, and the parent can take it to the GP. I'm moving on from asthma. I don't know what it is, but this year has been a really bad year, and literally everybody I see is coughing and wheezing. And it feels to me like older children as well, which is why we've included this in the primary school age children, because I've definitely seen 5, 6-year-olds wheezing. This is quite important. There's a difference here. So episodic wheeze is a child who wheezes only with upper respiratory tract infections and is otherwise totally symptom-free. If these episodes are mild, so they just need nothing, or they have a little bit of salbutamol, there's an excellent prognosis and no increased risk of respiratory symptoms in later childhood. Now, I've put the SNOMED code here because there are two differences. That's episodic viral wheeze or viral induced wheeze, but actually some of these children have suspected asthma, and there's a different code for that, so you will get more money. And the children with suspected asthma, they wheeze with upper respiratory tract infections and have one or more red flag features. And these are the features, and you'll see lots of these. So more than 2 admissions ever to hospital with wheeze, that's throughout their lifetime. Any PICU, HDU admission ever. More than 3 attendances to the emergency department in the last 12 months. I've definitely seen a lot of children like this. They wheeze, they come back, they wheeze, they come back. High reliever use, so more than 3 metered dose inhalers of salbutamol per year, which was what I was telling you was a sign of poor control. and any interval symptoms. So I always ask these children, are you wheezing with exercise? Are you wheezing with allergen exposure or dogs or cats or whatever? Track is a specific school for asthma, so you probably won't have time to go through that. But I think it's really helpful to think of these as two different conditions and to mark these children, because you also have a problem in GP practice that you can't always do lung function on a 5-year-old, but you can code them as suspected asthma and treat them as such, because some of those children I will start on Clenil inhalers or Montelukast. So I hope that makes that distinction for you. The good thing is on beat asthma, we also have this viral induced wheeze management plan, which you can just print off, and it's got everything on it. So you just put their name in, it goes through what's wheeze, how can I prevent it, why is it different from asthma, how do you treat it, and then on the other side it's got green, amber and red. So it just goes through all of that, and I think this is really, really useful, and we give these out a lot in the emergency department. So that's just going through asthma and viral wheeze. I couldn't cover everything, but I'm trying to cover the things that I think you'll find helpful and find on Healthier Together. So I'm moving on to the second A, which is allergies. And the secret here is avoid, identify, and treat. So avoiding known allergens, again, this is the same thing. It's making sure that the child, the young person, the school, the nursery, all have the right information. So do they have an up-to-date allergy plan? Are the staff wherever the child is aware of their allergies? This is really useful. This is on the Beat Anaphylaxis site, which is linked on our website. And this shows you all the different supermarkets, and there's a link to their allergy notification. So you can see in each product what's definitely in it and what the high allergens are. So these are the kind of things I think you don't always know are there, which are really useful and are really helpful to point out for parents. I put this in. I hope you won't be seeing too much anaphylaxis. And I put this in because the guidelines have relatively recently changed. And the big change, and I know this is an issue because I see it in our staff in the emergency department, is the only treatment for anaphylaxis is adrenaline. And time again, I see parents and I see children and I see my junior staff giving salbutamol, giving antihistamines, giving steroids, and actually they just need adrenaline. And we all have a kind of antibodies to it because it feels horrible trying to inject a child, but it's just as a reminder. So if somebody comes into your, let's say, primary care practice and they've had a sudden onset of airway and or breathing or circulation problems and a skin change, and they say they've had an allergy exposure, then first of all you need to call for help. Then you need to remove the trigger if it's around and lie them flat. So don't stand them up because they might faint, so sit them down or lie them flat. And the life-threatening problems down here are hoarse voice, stridor, increased work of breathing, wheeze, fatigue, cyanosis, low SATs, low blood pressure, signs of shock, confusion, reduced consciousness. And I reckon we see a lot of children who come up, they're a bit itchy, something swells up, the parents give them a bit of antihistamine, and then in a fairly short time they start wheezing, and people don't think of it as anaphylaxis because they may not look really sick at that point, but actually what they need is adrenaline. So give that intramuscular adrenaline. Don't be frightened. You will never do wrong by giving too much adrenaline. It might make them a little tachycardic, but it won't do them harm. If you don't give the adrenaline and they progress and they go into intractable shock, then you will do harm. So it's always better to give than not give. So remember, give adrenaline, give them oxygen, and if there's no response, give again in 5 minutes, because trust me, you will still be waiting for an ambulance, although I know you would have called for one. I've just put the links to Beat Anaphylaxis and our allergy site. There was 2 quite useful scenarios from Beat Anaphylaxis. And I think you see this now and again. Sometimes you see somebody who gave their adrenaline in the community. They might have eaten something with a peanut, realized that they were in anaphylaxis, given the adrenaline, and then they come and see you. What do you do then? It depends how long ago it is. So if they've well and they have no residual symptoms and it's more than 6 hours after they gave the adrenaline, you don't need to do anything else. If they have any residual symptoms and it's only like, I don't know, half an hour because they've just given it and run into your surgery, then you might need to refer them, send them to the emergency department where we will keep them for the rest of the 6 hours and make sure they're okay. The other scenario is the child who doesn't know. So maybe this is a sibling and they ate something and they had wheeze and difficulty breathing. So because maybe they didn't know they had anaphylaxis, this is the first time they've been given shellfish or peanut or whatever it is. So they've had some symptoms 4 hours after eating the new food, but they've not had the diagnosis yet. And the parent gave them some antihistamine because they had it around the house, and gave them some salbutamol. Oops. And the symptoms are better. What would you do in this case? So this is already like 4 to 6 hours after the event. They haven't been diagnosed. So in this child, you need to think about, do they need steroids? Because are they going to have a late phase reaction? Do you need to refer them to the local allergy service? Do you need to prescribe them an adrenaline auto-injector? And that's a kind of worry, because what happens if they get exposed again before they get their outpatient appointment? Or do you need to just discuss it with the local team and make a plan so that you give them, say, one auto-injector and then they get referred and they get a proper diagnosis? So I think that is also a relatively similar scenario. So I hope that makes that clear. I'm moving on. I've done 2 acute conditions, allergy and asthma. And I'm moving on to the core 20+5. And these conditions were identified because they were key clinical areas where there was health inequalities for children and young people. So we talked about asthma. We've got asthma, diabetes, epilepsy, oral health, and mental health. And there is advice for all of these on Healthier Together. So you'll see under our long-term health conditions, we've got asthma resources, anaphylaxis, which I talked to you about. There's a bit about diabetes, and we've linked it to Digibeat because we know that those are really full. We've just uploaded a whole load of information about epilepsy. We did add eczema because we thought you get asthma, allergies, and eczema. And our rheumatology team are really forward thinking, so they've got a lot about that. It's there for their own patients. But those are the things, rheumatology, you don't see that often. Constipation, we see it all the time. Anybody who's not coughing is clearly constipated. So this is one of the things that I see all the time. So I thought I would go through constipation with you and what our resources are and what you can do about it. And we've got a new section complete for bladder and bowels. So at the moment, nationally, 1/3 of 4 to 7-year-olds are constipated. And chronic constipation occurs if you've had symptoms for more than 8 weeks. The important thing to remember is 95%, so almost all of them, are idiopathic. The first thing is to take a history. So any child who's got really large stools that they say block the toilet, they're constipated. Children passing hard stools or rabbit pellets. Children who say they've got blood in the stool or blood when they wipe after the stool. Children who are straining or soiling, that's constipation. And the soiling one is really important because they often say, oh, they have constipation and diarrhea, but it's usually overflow. So if they're passing little rabbit pellets and then sometimes having diarrhea or overflow, that's most likely constipation. Just to remind you, children with recurrent UTIs almost always have constipation because if they are not opening their bowels, their distended rectum is pressing on their bladder, so they're not emptying their bladder and they get recurrent UTIs. The thing you'll be most happy is you can refer anybody who lives in a Newcastle postcode to our bowel and bladder service, which is great, but I know it's a problem on the edges. So just going through, what are the things that you should really worry about when you're thinking about constipation when you take that history? We're always happy to see anybody who isn't growing properly. Anybody with other medical conditions, so if you're constipated and have cerebral palsy. I think the most common one is personal, familial, or social factors. So, can families follow treatment plans? And I would say that's the one where the bowel and bladder team have the most work. That some families, it's quite intensive. You need to fill out a lot of things. You need to be a consistent parent. You need to encourage your child to eat a good diet. You need to get medication in them. And this is a really common problem. The families who are chaotic and disorganized and have 6 kids, you know, a single parent, they're the ones who struggle with this. The bowel and bladder team also happy to see ones who don't improve with effective treatment after 3 months. The 5% who have problems, look out for these red flags. So symptoms from birth, delayed meconium. I think most people are really good about asking about this. New or undiagnosed weakness in the legs. And abdominal distension with vomiting, so you're wondering about bowel obstruction or fecal impaction. Any safeguarding issues? So I had an example where I had a child in clinic, and every time the stepfather would work away and come back home, every time he came back home, she was constipated and soiling. And we were convinced that this was a way of protecting herself from further sexual abuse. New onset constipation in children older than 5 years. Of these 5% with red flags, I would say the most common one we see is this one. So very occasionally in pediatric practice, maybe I've seen one, and I know Paula sees a couple, is children who actually have undiagnosed weakness, or the child I saw was a lot older, came to me with constipation, but when we took the history, he was getting up at night to go for a wee like 4 or 5 times a night. He'd always been like that, and they had undiagnosed spina bifida occulta. So now and again we pick that up, but it always comes out in the history. All the information I've just given you is on our constipation pathway, which is under the professional side. So I've talked about history. There's a nice Bristol stool chart there for you, tells you what to look out for. There's your high risk flags and your amber flags. And this is the most important bit. There's a nice disimpaction regime there for you. Most of the children will fall in the green section. And if you want to start some move colon, you feel confident, we've given you some guidelines there. So I hope that helps you with constipation. This is the parent page. So you've just looked at the professional page. This is the parent page. I would strongly advise you, even I've watched this video. This is Claire Waters, our fantastic bowel and bladder nurse. And this is the video that they ask all children coming to the bowel and bladder clinic to watch, and explains all about constipation. It's got some really nice diagrams, and she goes through everything. So I often remember, when you want to share this, you need to click on the yellow box at the top here to share that link. And all this can be, all the writing, but not the videos, can be, if you press recite me, it will be translated into 100 different languages. But I would strongly recommend watching the video. It's really useful, and I did it myself. So constipation just brings me nicely onto functional abdominal pain. And I really put this in because I see quite a lot in clinic, and I think it's one of those things that takes up time. And I think that people don't feel confident about dealing with it. So functional abdominal pain is quite common. There's lots of things that lead to functional abdominal pain. So there's something about your microbiome and changing that. And there's something about early life events and stress and how you cope that means that you get hypervigilance, disordered microbiome, and hypersensitivity. So you feel pain from what is a normal process. So our gut works, and we normally don't feel it as pain, but some people do. So the pain is real, but there is no underlying cause. And there are very specific definitions for this. So recurrent is 3 episodes over at least 3 months, severe enough to affect a child's ability to perform normal activities. And I call that missing school. Chronic is for more than 3 months. Functional is obviously if you don't find any underlying abnormalities. And this is really hard because I think parents are coming to you and they always think there's something wrong and that you haven't done enough tests. And if only you do another test, you'll find out what's wrong. And then you will have one thing that they can do that will take it all away. All recurrent non-specific abdominal pain can be defined under this Rome 4 criteria. So you can get abdominal migraine, which you probably know a lot about, functional abdominal pain, functional dyspepsia, or irritable bowel syndrome. So that's how they divide it up. From your point of view, I guess what you want to know is, when do I need to worry? When do I need to refer children with tummy pains? We're happy to see anybody who has chronic severe diarrhea, particularly diarrhea when they're getting up in the middle of the night. Anybody who's not growing, delayed puberty, bad dysphagia, anybody with a family history of inflammatory bowel disease, obviously GI blood loss, I think you would do that anyway, involuntary weight loss, diarrhea that wakes them up and pain that wakes them up, we worry about, and persistent right upper or lower quadrant pain, significant vomiting or unexplained fever. So those are the kind of things that if you want to make a referral, if you've taken a quick history and they have those, then just refer them into general peds. The parents always want to know, what is causing this pain? And how do I know that you haven't missed something? And I often talk to them about safety netting. So I say the most important thing is to take a really good history and make sure they don't have any of the red flags. And I go through the red flags with them and say, your child is growing fine, they're on the 90th centile, your child is not missing school, your child is this, and that helps them. So safety netting is taking a history, both the GP and then maybe us, and then examining them and not finding anything. And we always consider at some point, because sometimes the GPs will do this beforehand, doing some baseline blood tests. And these are really straightforward. So there'll be a full blood count, renal and liver function, and one of the inflammatory markers. We almost always use CRP because it's easier and takes less blood, and a celiac screen. Stools, if there's a reason, I do MCNS and overcystin parasites if they've been on holiday, if they've been abroad, if they live on a farm. I don't routinely do that, but I often have a look for Helicobacter pylori. So I'd send a fecal antigen for that. They all need a urine dip and an ultrasound if they had right-sided pain, jaundice, urinary symptoms, faltering growth, or any other abnormalities. So that's a kind of quick what things. You can always do those before you refer and we would still see them, but it's really helpful. This is actually from King's, but I quite liked it. I'm going to try and move it up here. So we've talked about what to ask about. We've talked about the red flags here. Helpful diagnostic features. Think about epigastric pain. Is it a gastritis? Think about teenagers. Is it a gynae issue? Abdominal migraine you'll be used to. If it's none of these, think about celiac screen and doing your bloods. Now, if you decide it is functional abdominal pain, it may be something that you can just reassure the family and explore the stresses. You could talk about how you can use simple analgesia. They can try lactobacillus and peppermint oil, and they can use buscopan and mebeverine if they're a bit older. One of our consultants has a really nice analogy. She talks about it being a faulty fire alarm. So, for example, if you're at work and the fire alarm goes off, you all run out the building. Somebody checks the building, there's no fire, you go back. And if the fire alarm is faulty, then it keeps going off and you know to check the building to make sure there's no fire. But if there's no fire, you just stay and you carry on working. And it's a bit like that. So they'll keep getting abdominal pain, but we know there is nothing desperately wrong with them. And we need to reassure parents and empower them to just cope with the symptoms and the pain and know what to do, and not to keep thinking, oh, I need more tests, I need more done. So it's really common, 13% of normal children, and 2 peaks of age, 4 to 6 and 7 to 12, Oh, they say don't forget to inspect the anus. That is important if you're thinking about inflammatory bowel disease. Consider stressors. It's almost always school. And just remember, all these things can be associated with sexual abuse. So please think about asking about that. So the treatment is all about reassurance and advice, which is where I think it's helpful to use Healthier Together, because you're trying to improve the child's quality of life and reduce parent concern and try and get them back to a functioning state. They can try lactobacillus, they said. Cognitive behavioral therapy and hypnotherapy work, which is great, but of course we have no access to psychology or psychiatry, so that's not so great. However, on some of the Healthier Together sites, we have a lot of advice about functional pain, how to treat functional pain, and what to do. And I think that gives parents a starting place, which can be really helpful for that discussion. So after I've made us so tired thinking about functional abdominal pain, which is one of the things that I always worry about, I don't think I do it very well, I'm going to talk about sleep. And we all know how important sleep is. And in primary school age children, they still need 9 to 11 hours. And we've got a lot of really useful top tips. So I'm sure you're aware of this, but it helps parents if you talk to them about it, and then they can go and read about it on our website. Lights off, quiet, smoke free, no screens in the bedroom. This is really important. Children who don't sleep well, they need to be tired in the day. They need to go out and get natural light and do exercise in the day, so that they know that helps their diurnal rhythm, and so they will start to be tired at night. Children who are anxious or worried, thinking about having a diary to talk about and write down their worries and be consistent. And I know this is the hardest, and I know in some families this is really difficult. The next thing I thought I'd bring up was something around neurodiversity. I'm just going to show you this page. I can't make a diagnosis of autism or ADHD, and neither can you. But we know there are hundreds of children sitting there waiting. I think the wait list is like 5 years. There's 5 years of wait list, but most parents are waiting a year or two just to get a diagnosis. So these families come to you and they ask you for things. And what I say to them is, I can't diagnose your child, but I can show you this page, and you can look under this page. So, is my primary school age child autistic? And see if there's things that you identify that you think are problems for your child. You can share this page with the school, and with that information, it can help you to either get that support more quickly or to be more directive about what you do. And the most important thing is this local resources. So this is Helen Leonard, who is one of our autism consultants, and she has these 6 videos navigating the system. And then she's also got communication, eating, well-being, sleep, and toilet training. And I think this is a fantastic resource, because they have these problems already, and you can say, well, I don't know if this is diagnosis, but you're struggling because your child is fussy eating. Go and watch this video. We can talk to the dietitian. We can get you some advice, so that while you're waiting on that waiting list, you're not doing nothing. And I think it helps me to have something to share with parents while I can't make that diagnosis. And along those lines, I thought I'd talk about tics, because this is something I see a lot in my outpatient clinic, and I'm guessing that you see it more than I see it. So I just thought it would be a good thing to just quickly go over. I always ask parents to get a video, because it really helps making a diagnosis. Although most of the time during the consultation, I'll see the child tic. There's a few things you need to ask. And what I generally do is I open the professional page, and then I have it open and I make my notes. So ask when it started and how long the tic's been present. What kind of tics? Are they motor or verbal? And verbal isn't necessarily words. It might just be vocalizations. So they often do funny things with their throat. So you get like that. So you're thinking about the range, the frequency, and severity of tics. These are the things that make you realize it's definitely a tic. So ask about triggers, or when the tics get worse. So do they get worse when they're tired? Do they get worse with stress? Ask about the premonitory urge. So people who tick, they really want to tick, they feel like it's coming on and they get this urge to do it. And until they've ticked, they can't stop thinking about it. So that if you describe it to them, they'll often say, oh yes, I definitely have that urge to tick. Are they able to suppress it if they really need to? And does it have a sort of waxing waning course? So it often gets worse in sort of puberty and then gets better after that. What is the impact of tics? Does it disrupt normal activities? Does it cause pain or injuries? And what's the social and emotional impact? The thing that you want to do is rule out other things, like is it a seizure or a movement disorder? So is there any loss of consciousness or collapse? Have they got injuries like tongue biting and incontinence? Do they ever have funny movements in sleep, or do they have continuous abnormal movements they can't suppress? So those are sort of features I would worry about. The other thing is that we know that tics exist in common with other comorbidities, so like ASD, ADHD, OCD, anxiety. And often it's more important to treat this and then the tics will get better. All they need is a full neurological examination, and generally that should be normal apart from seeing tics. So this is the primary tic disorder pathway, and I find this super useful, and it tells you here if you just need to reassure them and give them advice on our website. If you're not certain about the diagnosis, or if there was a abrupt onset, or they are impacting on the child, that's when you should refer them to us. So in summary, I've gone through some acute conditions, thinking about good control in asthma, plans, identification and plans again, and how you can find those on Healthier Together. Long-term conditions, and I hope you'll treat constipation with confidence. You'll be able to reassure families with functional abdominal pain better. Some common issues, I've pointed out resources for neurodiversity and tics. So I'm going to stop sharing. Oh, sorry, I was just going to ask if you had any questions, and also ask for your support as a champion and to stay in touch. And I'm going to stop sharing so I can see you, but I'll put this up later at the end so you can have a look. Right, fantastic. So do you want to turn your cameras on? And I believe we've got 10 minutes, 10, 15 minutes for any questions. Oh, I'll look in the chat.
Has anybody got any questions? If you want to put your hand up, please do so.
I need to leave for clinic commitments. Yes, I feel your pain. Anything that you don't feel confident I didn't cover that you would like to ask me, this is your chance. You've got me. Is there anything?
No questions at all. We've got everybody stunned to silence. I'm a school. I've got one question in the chat. I'm a school nurse in an independent school. Can I refer to bladder and bowel?
Yes. Yeah, as long as they have a Newcastle postcode.
And I would assume there'd be other services in other trusts.
Yeah. Is Lindsay there? She's being shy. I can't see my screen.
Hello, no, I'm just being muted.
Lindsay, I mean, we spend so much time with bladder and bowels. Absolutely, yes. If they have a Newcastle postcode, they can be referred to our service. There is some problems because especially out towards Gosforth, they might get a Northumbria postcode. They might actually, NSEC is there. So they have to go through NSEC bowel and bladder or NSEC general paediatricians. So there are areas like Hexham and Gosforth where they have to go via NSEC, which causes issues, but I can't help you. But what we did to get around that is we put all our information on the Healthier Together website. And as a start, I would get them to just like watch the video. Claire's video is amazing. I mean, it takes, I watched it in naughty double time speed and it still took me 15 minutes, but it goes through it really nicely about what it is. And then I think that we also put the bladder and bowel charts that they can fill in. So they say what medication I'm on, how many times I'm opening my bowels. And that's a really great start because then they can feel like they're taking control of the situation, and it gives you a really good start to sort of referring them on. Is that helpful, or are you struggling in any other way that I can help?
No, that's good to know. I just I've had issues referring into NHS clinics and services before,
Yeah.
and they've had to be requested that it comes through from GP or NHS school nurses. So
Yeah.
just wondered about bladder and bowel, but that's good to know.
Anybody else having bowel problems?
We've got another question in the chat from Gemma Wood at Redburn
Oh,
Park
yeah.
Medical. How do you decide if you treat for disimpaction pathway or treat with first line for acute treatment? And do you taper down sachets of Movicol if you only use short term?
Oh, that's a great question. So, if they are having any soiling, well, this is a really good question. If they have soiling, if they are sometimes with us, and you may not want to do this, we do an X-ray. This is almost always the families where they have started and they take some Movicol and they come back and say, it's not worked, nothing's worked, I think there's another problem. And you do an X-ray and you see this huge distended rectum. So if they have a distended rectum, if they have soiling and signs of overflow, if they haven't opened their bowels for like a significant period of time, like a week, then I would do a disimpaction. Interestingly, the disimpaction that we use there is the one we've put the easier disimpaction regime on Healthier Together. So I think it goes 2, 4, 6. It says start on 2 sachets and increase by 2 sachets every day. Paula and the bowel and bladder team do it the other way around. They start on 12 and go down because you're more likely to empty them out. But we did understand that was a very like aggressive way if you haven't got the family on board. What I usually say, so my spiel to parents is, where's Gemma? Ah, you're here. I say to them, I think your child is full of poo. And the only way to deal with this is to clear them out and then to get them opening their bowels regularly. You want to do this at a weekend or a holiday, because when you do this disimpaction, you need to be near a loo. So they've always been constipated forever and ever. So it doesn't matter if they wait a week or two till half term, but then you go for it in half term. You say, just clear half term. This is the time you're going to get disimpacted. You're going to take Movicol until your child is passing clear water, like literally clear watery diarrhea. At that point, however many sachets you're on, let's call it 8 sachets, then you halve it, and that is the number of Movicol that you're going to need all the time. So if you got up to 8, and 8's what it took to disimpact you, then your day-to-day prophylaxis regime is 4. Does that make sense? I always tell, Gemma, can you hear me?
Sorry, I'll put my mic on. Yes, I can. Thank you.
The other thing I tell parents is you will have to take Movicol or whatever laxative they choose, but Movicol is the first line for as long as you have been constipated. So if you've been constipated for a year, you're going to be on laxatives for a year. It's no use taking them, disimpacting, and then after a week stopping and then wondering why you're constipated again. Because I think that's another really common thing. So I try and get them to understand they need to disimpact and they need to carry on. Otherwise, it's straight away going to come back. The biggest problem is why are children constipated? I would say a lot of it is diet. So we know that a healthy diet is really, first of all, we know a healthy diet is really expensive. Fruit and vegetables are very expensive, and they take time and effort to prepare. So you need to have the time, you need to have the electricity, you need to be able to pay the electricity bills, you need to have the knowledge and skills to make a healthy diet. And I say that because I've done a lot of work with the West End Food Bank. And if you are in socioeconomic problems, then actually trying to eat healthily is a real issue, because it's expensive, it's difficult, and frankly, you're just about managing to get out of bed and get everybody to school. So that's one issue. The other one we have goes back to the undiagnosed people with autism spectrum disorder who have fussy eating and a very limited diet, which is like another issue. But the number of children I see who I come in and I say, what are you eating? And they say, I'm eating sugary cereal and turkey dinosaurs, chicken dinosaurs and sausages and no vegetables. I mean, it just seems like everybody is on that diet. And unsurprisingly, they're getting anemic, constipated, etc., tummy pains. Can you tell that I do this a lot? Do you all do this a lot, or is it just me? I'm seeing nods. Yeah, okay. You're all feeling my pain in that case. So I think that this is a real issue, but I think that I can't, I can give people advice. I can lead the horse to water. Sometimes for many reasons, I can't get the horse to drink. So it might be they don't have the resources, they don't have the knowledge, they don't have the parenting skills, or a combination of all of those. But I think it's a really big issue. So really good question. I'm sure lots of other people had the same.
Yeah, we've got another question in the chat of Carolyn, and it's any advice if parents are advising the child will not tolerate, take bowel medication, but continues to have constipation and swelling?
Oh, how I laughed. That's the other half, isn't it? This is a really interesting one. Where's Caroline? Caroline?
I'm here. Hi, sorry.
Can you give me a bit more background to who it was or what the situation was?
Yeah, he's currently being assessed. Well, he's on the waiting list to be assessed for a neurological assessment anyway. But Mum's saying that he won't tolerate or take bowel medication. Obviously, I've explained the importance of taking it, but like I think taking it like the Movicol in orange juice I've heard as well before potentially. But they're just literally not taking anything.
Is it for autism, or is it because he's got cerebral palsy or something?
No, it's for autism.
It's for autism. So the autism ones is really difficult because that combines with the fussy eating. So they won't drink it because of their fussy eating. In autism, I would just mix it with whatever they are drinking. So for some reason, they tend to like fruit shoots, flavored waters. So they need to mix it in whatever their favorite drink is. They need to do 62.5 mils. Every sachet needs another 62.5 mils. So that's 125 for 2. So that is an issue because that's quite a large volume. And sometimes these children don't drink much. Sometimes with these children, they prefer lactulose because it's a smaller volume or they like the taste. So it's really exploring what they like to drink. Once you've got them on enough stool softener where their stool is soft, I then add picosulfate to make their bowel more active as well. But it is difficult, and I would explore with the parents what they drink happily. And they would have to do it very slowly in these children with lots of reward. Totally sticker chart rewards and then slowly introducing it in. I've had some parents like this who are really nervous about mixing it with their favorite juice because they were worried they would stop drinking their favorite juice and then they wouldn't drink anything at all. So it is a difficult situation, and I think you need them on board to try and work through what they can manage and encourage them. It's like everything, it's routine. So I often say to parents, it's like brushing teeth. Once you've got them to brush the teeth, how did you do that? Did you do it in little steps? Did you do it with reward? I often say, just give the Movicol before you brush the teeth. It becomes part of their everyday regime. They give they take their 2 Movicol, they then brush their teeth, they then get their sticker or their star, and at the end of the week, you count up all their stars or what have you. But it's very much like, how do you bring this into their normal routine?
Thank you.
Does that help?
It does, thank you.
You have all my sincere, you have my absolute, it's really difficult. But go and watch the video. Did you know the video on the links under local neurodiversity resources? There's one on toilet training under that.
Okay, great, thank you.
Is that another question from you? I have.
But somebody, yeah.
Is this you again, Gemma?
It's somebody called Gemma, yeah.
That's it. No, don't apologise. Questions is good. People who ask questions are my
Just found
favourite
out
people.
This morning, so it's just fresh in my mind.
I have it first line to give Movicol and then add in lactulose. Can it be done the other way around if on lactulose already but on increasing? So lactulose and Movicol are the same. Both of those work by stopping the bowel absorbing the water. So they're an osmotic laxative. So I tend to give them loads and loads of Movicol. Once their poo is soft, I would then give them something like docusate or picosulfate, which actually helps the bowel start moving more. So it depends. We tend to give Movicol first. If they don't like Movicol, I would give them lactulose, and then I would add in something like picosulfate or docusate, which is just a different, is not an osmotic laxative, it's a stimulant laxative. Does that make sense?
It does, yeah. So if so I had a young girl that was already on lactulose, but afterwards I'd said that she was only on like 2.5 mils twice a day. She could go up much higher. So would you just keep increasing that?
Yeah, and that's a baby dose. So she could easily be on 10. How old is she?
3, I think it was.
Oh, 3. Easily 5 mils twice a day, 10 mils. So I would go up on that to a reasonable dose, and then once the poo is soft, if it's still not coming out, add the stimulant.
Okay, fine, thank you.
And just go and watch the video. Watch Claire's video. She knows much more than me. She's an absolute mine of information on anything to do with bowel and bladder. Okay, I think we...
Yeah. Anybody got any further questions or before we close the session?
Excellent. Could I just ask everybody, was those topics that were helpful to you, or were they things that you knew about all already? I can just see a few nods.
Very helpful.
Was there any helpful? So the right kind of topics.
Definitely.
Yes.
Definitely.
Is there anything else you would like to say?
What was missing for school-age children were the things. So this time around we have split it into under ones, preschool, school, and teenage. But we're just really interested to know what helps you. I'd love to come and see a school, actually, Northern County School. We're doing, just on a sidebar, we're going to start doing some work introducing pill swallowing in school curriculum. So I'm quite interested in that, because I'm very keen that all the people on melatonin swallow it as a pill, not liquid, because it makes their life so much better and cheaper.
Leanne Parker, you got your hand up?
Yes, I'm sorry, I'm in quite a noisy office actually. I'm a school nurse in Newcastle, and we are having lots of issues with young people with sleep. And we've got sleep workshops, and we've signposted this website, and we give lots of advice that's kind of already been discussed. We get a lot of young people who are on the wait list for neurodevelopmental assessment, and they're going back to the GP and saying we're doing everything that's been asked of us, it's still not working. They want melatonin. They're not going to get melatonin from the GP. They're not going to get it until they've got a diagnosis from SIDS. They're on a 4-year waiting list, and we've got parents just at the wit's end. What do we do in those cases when parents are following all the advice and they're just kind of getting to crisis point, really?
It's a really good question, and there's a whole load of issues around sleep. What I would say, Leanne, is that probably if it was specific things, if you had specific long-term problems about prescribing melatonin, the person to email is Liz McClellan. So she is, I'll pop her email in the chat. She is one of our new consultants who is the only person in the region who has a special interest in sleep and has been trained in sleep. And all the pages on sleep came from her. And we did, actually, I think it's recorded. We did a session on sleep, didn't we, Laura? I think if you
yes,
look
we have. It's on the it should be on the lunch and learn sessions. We are planning another session with Liz. We were waiting. We need to get a new date to do another sleep session.
So I would look back to our old sessions, have a look, and I will pop her email in the chat for you.
Thank you so much. Thank you.
Brilliant. Okay, we're absolutely at the right
Yeah,
time.
the right time. Yeah, and we've got a topic of mention there, Emma, for our next session on things like growing pains and limping children.
Oh yeah, that's a great one. That's really good.
Yeah.
Yeah.
Well, thank you very much, everybody, for attending. We will be sharing the links and getting them onto the Healthier Together website in our Lunch and Learn section of the website, where we put all of our kind of recordings and presentations once we get a chance to get them uploaded onto there. Thank you again for coming. Thanks. Bye.
Thank you. Bye.
Bye.
Leanne, I've just put that. Elizabeth McClellan.
Thank you so much. Thank you.
Copy that email from the chat.